We're going into week 7 now. First of all, I know you want to know when your scores are coming out. They'll be out Saturday about 12:30, and I'll make sure that they're posted quick as I can. That's when we're doing our item analysis between all of us about 12 o'clock. So we get together, look at questions, and making sure that, the way I'm looking at it, somebody else looking at it, that it's a question frequently missed by students. Is it because of the question or it was because of knowledge? It's because you didn't know the knowledge. That's one thing, but the question wasn't worded right, so you couldn't get the right answer. That's the one that will just, kick it out. And I'm telling you, the one in aerosol is going to be gone. So, all right, week 7, endocrine, it's cerebral. Remember the next week, that's going to be what your quiz is going to be on, this stuff information. Also remember, next week is your pediatric assessment project. Make sure I have your diagnosis. I don't have everybody's yet. Now, if you do a portion, send the one portion in. I can look at it, I can give you criticism on it, tell you how to get it even better, or if it's okay to say, oh, it's fine just the way it is. So you get it in quick and just put it through the modules. Don't feel like once you put it there, it's set in gold. No, there's multiple submissions. So I write the little notes on the bottom. Things disappear, things come up. Don't worry about it. My notes on the bottom and what I, also keep will tell me what you needed in order to get that grade. Because I want everybody to get that 100 on it if you can. I mean, that's my goal. If you want that 100, you're unsure of yourself, send it in sooner. That's all I'm asking. All right, let's go. We're going to do a Kahoots today. Um, it's about 50 questions. I believe it's what's in it. And I'm going to be describing these things as we go over them and show you how that they're not as difficult words and concepts. You've heard them in med-surg, I believe already. You're just studying them. We sort of align up at this point in the courses. We'll be talking about thyroid. We're going to talk about pituitary, adrenal. And when we talk about all of those, endocrine things, got to remember what's pituitary, what is adrenal, what is thyroid, what is parathyroid. Keep them in their own little boxes, okay? And I'm going to try to show you how to do that. Now remember, as soon as those grades are posted, anybody who wants to know which 2 questions you got wrong or which 28 questions you got wrong. No, nobody had 28 questions wrong. But if you did, I don't care. Either way of the spectrum, you want to know something, you're not wasting my time. You don't know the answer, and I want you to get, that answer for you, okay? And I know what it's like when you think you did really great, but what was those 3 questions I got wrong? Anybody else joining me tonight? Or are you all just brains are burnt at this moment? I can imagine. All right, let's just go. Just listen, please. Just listen. I'm going to give you all the clues and hints you need. Cerebral and endocrine. So, head and endocrines, hormones. So, growth hormone is administered by what root? Well, the pituitary gland has everything to do with growth and fluid, anterior or posterior lobes. Sometimes children are small and the whole family's tall, so it's not normal. Well, we can give a growth hormone, and we will continue to give it until they stop growing less than 1 inch per year. The thing about a growth hormone, it takes a lot of commitment by the child and by the parent because it is a subcutaneous injection. It's like having to give insulin every day. So it is a commitment. Growth hormone, again, is the anterior pituitary gland, and it has to do with how they grow. Remember, if the whole family is short, you're not going to make a child grow more giving growth hormone. So again, something to look at with the assessment. Highest priority for a patient diagnosed with syndrome of inappropriate antidiuretic hormone. So SIADH is a big word, right? Let's break it down. Something's wrong with an inappropriate antidiuretic, which means against urinating. So break down the words. What does it mean? Against diuresing or against urinating, what is the highest priority? Absolutely. It's intake output because this child, even adult, antidiuretic means they're not urinating hormone. We're going to be watching how much weight are they gaining? How much, intake is over it. And then we're going to look at fluid balance. So strict diagnose and daily weights. Absolutely. Which of the following are signs and symptoms of an inappropriate antidiuretic hormone? Like inappropriate against urinating hormone. What are you going to see? Does that make that terrible word seem less, scary? Absolutely. Again, it's fluid balance. You're not urinating against peeing. It's a decrease urine output. Absolutely, that's a sign. And we would see an increase in weight. Your intake and output, more in than out. Absolutely. What is important to cover when teaching the family about cryopropathiacil? This is also known as PTU. It's for hyperthyroidism. Now, with every drug, there can be a side effect. And that's what this question is talking about. There's two hyperthyroid hormones. Just block the amount of thyroid hormone delivered. Well, with this one, the side effects that we look out for and tell patients about is risk of fever or sore throat. One of the things that I've learned with bad sinuses the last 10 years is that there are side effects and there are things called drug fevers. Clindamycin, I had 103 fever, just a drug fever. I was reacting to the antibiotic and I had to think, wait, I don't feel bad. Why do I have a fever? And then I had to realize it was the antibiotic that was causing it and stopped it. So you would tell them, you don't feel good, you're sick, sore throat, call the doctor. Are we going to prophylactically treat this? Or are we going to have them come in and look at thyroid levels, et cetera, et cetera? Okay. Multi. An initial sign of diabetes insipidus. Well, diabetes insipidus is the posterior pituitary gland. And diabetes insipidus is all about fluid balance. Remember, there's a fluid balance and growth. That is your pituitary gland. Because it says diabetes, it has nothing to do with blood sugars. Okay? Diabetes mellitus is blood sugars, pancreas, and carbohydrates. Diabetes insipidus is the posterior pituitary gland that doesn't know how to work with fluids. And what happens is you start getting thirsty, you're insatiable, thirsty. No matter what you do, you're thirsty and you're urinating. Even stop putting in it, you're still going to urinate. Now, diabetes insipidus is two things, two P's, polyuria and polydipsia. Diabetes mellitus is three things. Because you're not eating sugar, it's not being used in the body's hungry. So polyphagia, you're hungry. So you're eating, you're drinking, and you're urinating. That's diabetes insipidus, diabetes mellitus. Multi. What are the clinical manifestations of juvenile hypothyroidism? Now, hypothyroidism in adults and children are all the same thing except one thing. What's the difference between adults and children? Well, children are still growing, right? And they need all of the hormones to and make sure that they grow. And remember, without the thyroid hormone, cognition is decreased. This is a child. One of the things about hypothyroidism is you can be born with it and people don't know. Nobody knew that it could happen. One symptom that you will see is a newborn born that does not have a stool within 2 days. And if they're not, they're going to check for the hypothyroidism because without that thyroid hormone, they don't think their central nervous system doesn't work right. Also, they don't grow. So that child wouldn't be lifting their head up by 3 months. They wouldn't be having an invol or reflex grasp, right? They wouldn't be doing the things that they're supposed to be doing because they're not there. So hypothyroidism, dry skin, sparse hair, constipation, cold intolerance. But it's going to be with children, your growth isn't going to be there because you don't support that with that hormone. A child's had a simple febrile seizure. What education would you provide to the parents? My first grandson. Now I have one, two, three, four, five, six grandchildren altogether, and only the first boy had febrile seizures. And I know what the mother went through because she was calling me, of course, the nurse in the family. Now, in any seizure, no matter what we need to do is protect them from injury, okay? And sometimes they have one, sometimes they have, a couple, but never more than one a day, usually with febrile seizures, they say. So, what are safety precautions? Well, if they're in a bed, you want side rails up. You want the rails padded if you can. They're having a seizure, turning them over to the side. They can vomit out. Have suction to suction that area, not the mouth, but the area to keep it free so they can breathe without aspirating. And then, children put all their toys and everything in the bed. Make sure you get rid of it because they can, tonic clonic, just like, grand mal, tonic clonic, and they could hurt themselves. So again, safety that's all of those things combined. What type of seizure is when the body is jerking, foaming at the mouth, and the child is rendered unconscious? They even go post-ictal with this. We've changed our names through the years. This used to be grand mal, right? We had petite mal and a grand mal. And depending on what book, the PNs still call it grand mal in their book. The RNs have it tonic clonic. They're both that arms and legs are thrashing, okay? Again, protecting them, safety. What notable sign may indicate increased intracranial pressure in an infant? Now, an infant can't tell you he has a headache, can they? Increased intracranial pressure could be hydrocephalus. Increased intracranial pressure could be a brain tumor. Usually the infant is more of the hydrocephalus. But the thing is, with these children, yes, you'd see a bulging fontanelle, but all the time. All children, infants, will have a bulging type fontanelle if they're crying. So that's not the one. It's a high pitched cry. You can walk into a room of 30 crying infants and you will know by the sound. It's just this, you want to put your nails on the chalkboard type feeling. It is a higher pitch, and you're like, that child has a neurological problem. You just know it's that high pitched, okay? It is notable. You can definitely tell. All of the following increased intracranial pressure except what? Now you have a child who has increasing intracranial pressure. You need to know what you can do to the child and what you can't, right? And they're just normal care. I think the biggest one that increases intracranial pressure is fluid overall because you need to watch intake and output, not too much in and not enough out. You're going to see more swelling in the brain. That's big number one. Now, bradycardia, tachycardia has nothing to do with cranial pressure. Coughing, gagging, choking, suctioning, turning, positioning, all of those can increase intracranial pressure. findings can alert you to a head injury getting worse. So it was always a child who was sliding into third base, their knee hit the head and they were rendered unconscious, but they were safe at third base. And of course, that child has to come to the ER because they were knocked out unconscious. They walk in there into the emergency room, and you're going to hear them ask the same thing. Was I safe? Did I make third base? We had to leave. Did we win the game? Did we win the game? The same thing over and over. It's that change in level of consciousness. Absolutely. There's extra pressure going on there. Good. A multi. What does it mean when you see a fixed and dilated pupil after a head injury? I think what all medical professionals who work in a trauma area and ER have anybody, the kid who comes in who has fallen and really injured their head. The one thing we do is open the eyelids and look at the pupils. Are they dilated or are they, working? Are they responding to light? If you have a fix, whether one or two, it's an emergency because they're telling you that the brainstem of the heart of the brain is the major part which does all your vital signs. Your heart rate, your blood pressure, your respiratory rate, your temperature regulation. And if that gets swollen upon, you have literally disrupted that main function. We need to get neurosurgery there and we need to relieve pressure now. Okay, that's what that's telling you. And the quicker we get it relieved, how much more is going to come back. There's going to be some damage, some neurological damage, as quick as we go. But this is true, real emergency, and they need neurosurgery to relieve pressure as quick as possible. So, what medication may be used for a child with cerebral edema due to a fall? Now, in pharmacology, you were taught about diuretics. Which one works on the head? Do you remember? And that's mannitol. So when you have cerebral edema, there's some fluids in there for whatever reason. Furosemide is peripheral edema in your lungs, okay? Mannitol is absolutely for the brain, and remember, it's white. Um, you have to look at it. If it has crystals, you shouldn't use it. You need a good filter on it, and you will see a sudden pour of urine output coming out, and it's coming right off the brain. Ray's syndrome was part of this chapter. We talked about it before. And the one thing we don't have here, remember, Ray's syndrome is also something that occurs after some sort of viral infection. Bacterial, no. Strep throat, no. Bacterial meningitis, no. Usually it's things like influenza that will cause Ray's syndrome when you took an aspirin because you have that metabolic disorder. And of course, this with kids, we usually find it out. Febrile seizures usually occur in what? The one thing that I think parents of children who have a febrile seizure need to know, it doesn't mean they have epilepsy. One seizure does not denote that. And usually they grow out of it. So usually it's about 3 months it starts, or 6 months it starts, and then about 6 years it stops. Now, my daughter-in-law still takes temperatures regularly on the child who had a febrile seizure. He's 11 now, but she still carries a thermometer around. It really unnerved her that much. So, yes, usually they grow out of it, and he did. Child hypopituitarism results in which condition? So remember, there's growth and there's fluid balance. This is the anterior posterior, the anterior pituitary gland. And that was just a pituitary dwarfism. Now, this child would not, do any well or any better with growth with a growth hormone because they have a condition on top of it. But usually means that the growth hasn't gone there. So either we just work with what we have or we can give that sub-Q injection. It's usually daily. How would you prescribe precocious puberty? So precocious puberty is when you get there too quick. It's usually the 6, 7 years old is usually pretty quick. So if we're seeing it like that, there's actually, because remember now they're going breast buds. That's the first thing we see, as they grow older, right? We're seeing maybe hair on a chin, things that at a 6-year-old child, other kids are going to tease them. So many times the parents say, let's block that puberty. And there's something called Lupron that we can give. You don't need to know the name Lupron, that's for pharmacology, but that's just the name of the medicine that you would use. A multi. Lab values are important to monitor with a child with congenital hypothyroidism. So remember, hypothyroidism with adults and children is we need to monitor it because they're not growing it the way that they should, right? Or their cognition is not where it should. So we need to make sure that whatever medications they get the proper dose. That is TS, T4, and T3. Growth hormones is the pituitary gland, the anterior. Cortisol is the adrenal glands. You see what I mean? But you need to remember what goes into which box. How can you monitor a child with hypo or hyperthyroidism? What's the one thing that makes it different than adults? And again, we're looking at the growth, height and weight. In fact, if we see a child not growing the way that they should or is a quick enough rate, this is something we might monitor. This child is lower than height and weight. All the family's tall. All right, what affects growth? Well, we would be doing the thyroid hormones, making sure are they abnormal or it is a true and real hypothyroidism child. What acid base alteration would you see in a diabetic child with Kussmaul respirations? So diabetes is when the body don't like sugar. It doesn't know how to take care of it, and it just sits there. And it says, I'm hungry, and it starts eating proteins and it starts eating fats. And with that, the byproduct produces ketones and it makes the child with metabolic acidosis. So Kussmaul respirations comes along and says, let me slow her down and push these rapid type of pushed and respirations. It's trying to compensate. What Kussmaul causes is respiratory alkalosis, which is the opposite of metabolic acidosis, right? So it's trying to compensate. Yes, we're going to give fluids. Yes, we're going to give insulin, potassium, whatever we need, but it's also the body's trying itself. And that's his mechanism to try to get back to where we should be. A multi. What would a child with Cushing syndrome look like? Well, this is your first adrenal that I'm talking about. Cushing's. Too much is Cushing's. Too much hormones, and it's usually too much steroids that we have given a child for too much amount of time. This child's got the big round face and these red, what we call ruddy cheeks. You're going to see hair like on the chin on a kid, which shouldn't be. We're going to see them fat around the trunk and the face. You might even see acne, and it's usually due to too much steroids. What do we treat it with? Well, we taper off those steroids slowly, and this will completely reverse. A multi. You walk into a room with a child who has a fever of 104.6 and they're having a seizure. So, what are you going to do? Seizures, what's our whole thing? It is always safety. So we're never going to do that cold water bath. Good job. But yes, check the bed for things that can hurt them. Turning to the side so that we can vomit out instead of choking on it. And of course, side rails up. They also say put the bed flat too. And if something's there, call for help. Push the help button. Autoimmune disease of the thyroid gland. This is usually in girls late childhood, early adolescence. And we usually will see the thyroid gland, and it's autoimmune, so we cannot do anything surgical here. This is a complete by medication that we treat it. It's called Hashimoto's. In fact, my daughter-in-law, she has Hashimoto's. Addison disease, the other side of Cushing's. Where is Cushing's disease? Adrenal glands. When you don't have adrenal glands too little, this is when we get into problems with sex identity. They're going to be ambiguous sexual organs with Addison disease. It has to do, there's not enough cortisol or aldosterone, and they're going to need supplements for life. And again, during periods of stress, just like any autoimmune, they might need a little bit more during those times. So, Addison, not enough. Cushing's is too much, and it's usually we've given it to them orally in prednisone. A multi, a ventricular peritoneal shunt. What is that for? What do we know nursing care of it? The question is so many things to it. So these children with a ventricular peritoneal shunt has had too much fluid on the brain or hydrocephalus, and the body's unable to drain it themselves. So behind the ear, you'll see this thing come out and this little knob there. It looks like something you should pump. Only the neurosurgeon should pump it. Goes down the front of the chest into the peritoneal area, and it drains fluid. So never pump it. We know it's for hydrocephalus. And our job, measure that head circumference, make sure it's not going up or down too far even. And even the abdominal circumference we would measure also. These children come into the emergency room as they get older, and the big signs and symptoms that there's a problem is vomiting, increased pressure, and headaches, increased pressure. And these children probably need a shunt revision, as we call it. Maybe it's disconnected, maybe it's too small now. So that's the ventricular peritoneal shunt for hydrocephalus. A common sign of Graves' disease includes blank or protrusion of the eyes. Graves' disease is hyperthyroidism. I don't know if you have time for TV, but they got these great eye commercials on about this, and the lady's wearing sunglasses, and there's eye drops they have for this also. It's called exophthalmos. So eye, protrusion of eyes, ops, that's eye. So exophthalmos would be that answer. And you can decrease it with some of the medications. It's still going to be a little pronounced. A multi. Hypoparathyroidism has the symptoms of tetanic muscle contraction and blank. Now, the parathyroid has nothing to do with the thyroid gland. All it does, it measures calcium levels. What does calcium do in the body? very similar to magnesium. It's all to do with the muscles. So if you have not enough stuff for the muscle contraction, you're going to be weak. Okay, you're going to be tetanic and, of course, low calcium levels. Makes sense, right? Another multi. What are signs of hyperparathyroidism? Too much calcium's going in. So with too much, you're nauseous, you're vomiting, you have so much stuff going on there that you're like a paresthesia that you can not feel your fingertips and you get really confused. And it'd be hypercalciuminemia. What does the parathyroid hormone do? So I'm making sure you get it. Because if you know calcium, magnesium, the function in the body, it makes it easier to remember. Yes, it's all about calcium. Which of the following might cause an adrenal crisis or an Addisonian crisis? Remember, Addison's is not enough, right? And what we could say is a sudden not enough, which causes this adrenal crisis. And because it's that Addison not enough, how do we treat it? We just give steroids because this is due to an abrupt withdrawal from steroids. So why do you think we get Medrol dose packs? It goes from 7 pills down to 1 steroids. They're trying to show you how you just go on a big dose on a day and then you decrease as you come off. So it's that abrupt withdrawal from steroids. And the treatment, they come in, they're sweating, they have a headache, they're hypertensive, give a dose of steroids and they calm right down. Multi-select. A cardinal sign of diabetes insipidus. I brought this back to see if you remembered what I said. Diabetes insipidus. The endocrine organ is your pancreas, right? No. Diabetes insipidus is your posterior pituitary gland. And what does that regulate? Fluid. It has nothing to do with eating because diabetes insipidus, you urinate and you drink and you urinate and you drink and it's just ongoing. You only get hungry when you can't dissolve and utilize the sugar in your body, right? That causes you to eat more or polyphagia. A multi. A congenital adrenal hypoplasia parent teaching should include. So remember, congenital adrenal, that's on your Addison side, right? Remember, this is all about sex assignment in children. I've seen one in my career. They had testicles and a vagina and a prominent clitoris, and they didn't know if it was a boy or girl. So what did we do, right? Well, number one, they went and looked at hormones, they did ultrasounds, saw body parts, and it was only for semantics because, boy or girl, they're still not going to have children. It's what they had outside that they can work with, to make them either a boy or a girl. These children will for life have cortisol and aldosterone replacements. And that's how, they continue because they don't have enough. Their adrenal gland doesn't work right. What causes type 1 diabetes? So remember, diabetes is an autoimmune disease. It's when the pancreas and those beta cells are destroyed. So insulin isn't produced, so you can't use carbohydrates in the body. That is type 1 diabetes. That means nothing else but insulin being given to the child will help digest carbohydrates. Which statement about a pheochromocytoma is correct? Now, this is actually an adrenal tumor. It's not Cushing's. It's a tumor that is actually very difficult to find. These children will have these symptoms of sudden headaches, chest tightness, tachycardia, and the blood pressure is very high. And what a pheochromocytoma is a very sensitive catecholamine producing tumor, which means it's like sympathetic. It produces something which makes everything go up, heart rate up, blood pressure up, that tightness, like you don't know what's going on. Most of these are initially, they look at the heart, they do cardiac monitors, echoes, and they think that's what it is. As nurses, if we're seeing a child having this or suspecting it, we would take vital signs. Let's see what the heart rate is now. Let's see what the blood pressure is and see if maybe it is that pheochromocytoma. A multi-select. Which action should a nurse implement in the care of a patient with a pheochromocytoma? Remember, this is the tumor in the adrenal gland that it just has sporadic elevated heart rate and blood pressure. So we're going to be monitoring for that. Has nothing to do with fluid, has nothing to do with sugar. It's the adrenal gland, and it just produces like adrenaline, epinephrine, everything goes up. So we would be monitoring for BP and heart rate. A multi. Nursing care of the unconscious child includes we think that there's differences between treating children and treating adults that they're unconscious due to whatever, anything. And something, they're very closely watched. Now, we would be watching neurosigns, absolutely vital signs, strict INO. We don't want more fluid in the brain. Pain control, it all depends. Maybe sedation, depending on what the condition was. With that unconscious, was it a head injury or just septic and unconscious? It depends on where it came from. What might you suspect if a child feels jittery, sweaty, and is dizzy? And yes, that's a hypoglycemic response. When you get these questions, read the question. The child said she feels jittery, she's alert and oriented. Or you would look at a child and the parent says, oh, she's shaking, she's sweaty. That's different. That would be glucagon, right? So it makes a difference in the way the question is worded. Be careful there. So symptoms of diabetic ketoacidosis is what? So you're a diabetic, your insulin doesn't work, so the sugar stays in the body. It's just there. There's nothing to use it. Then the body goes around and says, I'm really hungry and the sugar's not working. So I'm going to eat protein and I'm going to eat my fats, right? And you also see 4 plus ketones, 4 plus glucose in there, right? Now, fruity breath on these children smells like you took a peach, a nice one, covered it in a big sealed container, put it in the refrigerator for a month, take it out and it's rotten, right? Pull off the top and it's this sickening, sweet, fruity smell. That's what they smell like. They're oozing sugar out of their pores. That's what it feels like. And they come in, they can hardly hold their head until we do what? Give them bolus of fluids, dilute that sugar, and at the same time, let's give them some regular insulin. Nothing sub-Q, we want it quick. And the only insulin we can give IV is regular insulin. A multi. So an adolescent with a BMI above 95 has been urinating a lot. What test can you anticipate? How many things Could a adolescent who's large, that's actually an obese percent, is urinating a lot? What could it be? Well, it could be a urinary tract infection. It could be the hemoglobin. And if they're urinating a lot, you better look at those electrolytes. That's not clicked there, but it is a correct answer. So is it a urinary tract infection, or now are we talking about, uh-oh, this child might have diabetes? Hemoglobin A1Cs in children greater than 7 are considered, okay? In adults, is 6.5. They give a little bit more for children. Diabetic ketoacidosis is caused by. So DKA is caused by the lack of insulin, and it goes to proteins and it goes to fats and utilizes them. And then those byproducts are formed, which creates that diabetic ketoacidosis. The highest blood sugar I've seen on a child was like 1100 in a little bit. And his pH on his blood gas was 6.88. I mean, it's supposed to be 735 is the lowest, right? So that child was extremely ill. That kid made it, went to the unit, and did fine. But it was the worst numbers that I could have seen. It scared me a little bit there. A multi. A child's admitted with blood sugars greater than 600 and large ketones in the urine. What is your priority intervention? What do you think you're going to do now? What needs to be done? Well, as I said, blood sugar of 600, you need to dilute that now. So IV bolus. And we're going to put up a regular insulin drip and we'll titrate it slowly on, okay? Now, priority is not electrolytes. And as I said, nothing sub-Q. It's not quick enough. And the electrolytes, let's wait till we get the blood sugar down and that bolus in. Then we'll get the labs back and look at it. And if they need replacement, we'll look to do it then. It's not your first priority. Fluids and insulin. A diabetic child complains of feeling jittery. The blood sugar is 45. It's the best treatment for this child. Give them a cup of orange juice, cup of milk. Now, remember, that wears off pretty quick. It's quick sugar, whether it's milk or orange juice. Give them something with protein and carbs, like a turkey sandwich. It's always a great option, a turkey sandwich. Your patient's experienced a head injury. What would most concern you? Think about head injury, swelling in the brain. What happens when that does? What's in the brain that you're worried about? That's pushing on the pituitary gland. It's in the middle of the brain. It gets pushed and it stops the urinating from going on. That's telling me something's going on. There's pressure. Where's the neurosurgeon? Let him come and look and assess the situation. Multi. How do you detect diabetic ketoacidosis? Kids come in DKA and they're pale, they're really groggy, and by the time you give bolus, all of a sudden they're pink and alert and they're wondering what's on the TV channel. It's quite amazing how quick. So DKA, their blood sugars are up, ketones are there, and so is glucose. Dehydration, not necessarily, but everything is concentrated. A multi. What would alert you that a child's head injury is deteriorating? A little bit of everything. So, head injury is deteriorating. Now they're difficult to wake up. They've been confused. Now they're difficult. That becoming restless is like the hypoxic is going on, hypoxemia in the brain because there's swelling going on, occluding blood flow. And it's always headaches that are getting worse and vomiting not related to eating. And that's also brain tumors. It's occupying space. A child has been diagnosed with bacterial meningitis. What is the nursing priority of care? Bacterial meningitis is different from viral meningitis, right? When you have bacterial, what's your priority? What do you need to do like as soon as you can? And that's the antibiotics. These children will be placed on air flow room because it's all transmitted by air droplet. So they'll be put in one of those isolation rooms. Once they receive 24 hours of an antibiotic, we can take them off and they're no longer contagious to everybody. Okay. So, priority antibiotics. Yes, they're going to have a headache. Yes, give them pain medicine, but it's more antibiotics, number one. So, what is the primary cause of injury associated with submersion? Drowning. We can even say smoke inhalation. And it's hypoxia, whether the smoke blocked it, whether the water got in there and blocked it, and it can happen up to 72 hours later. You know how many children I've seen come in, they were drowning. They came up, somebody did something that got them spit up the water, and now they're alert, running around, and the parents like, my kid's okay. Well, they could go downhill very quick within 3 days. So we admit them to a step down ICU with O2 sat monitoring, just to be sure. It's all about the hypoxia. Last question in a multi. Which CSF lab results correlate with bacterial meningitis? You know, I've had many children come in with meningitis and we do a spinal tap. And I'm always looking for, what is it? Well, if that fluid is clear, almost all the time, it's going to be viral. Looks like this, white and milky looking, definitely bacterial. And that's all the elevated white blood cells that's in there. The thing about bacteria, they're hungry and they eat sugar. So it'd be a low glucose. And they don't like protein. So they leave it there. It's not about this increased white blood cells. And actually, it shouldn't have any red blood cells in it unless the physician went through a capillary. That's how we did today. Kimberly, good job, Kimberly. We got an E. Okay, E, good job. And number one, Libby, good job, Libby. And Mare Bear and Kirsten, good job, guys. So this is all I have for today. Remember, send me your what you want to do your projects on so I can help you with that. Get out of here. Now I did see, oh no, your class was okay, it was the other one. Anybody have any questions about anything regarding those projects? Know that I will be posting those grades by Saturday about midday. As soon as I get them, they'll be posted. I know that's hard for you to wait. Can you imagine the students who did it on Monday? So sorry about that, but we want to make sure that all of you get a fair exam, and we do that by looking at all the exams, making sure the questions were good for you. Okay? Thank you guys. Have a great night.
Thank you.
I'll be posting it shortly.